And I'm your host today on MainStreetMediaUtah.com. I am one of three co-hosts on the Wellness Crusaders Talk Radio. A little bit about our mission. The Wellness Crusaders internet radio show weaves together the critical and often overlooked aspects of wellness, including the crucial role of our soil health. This engaging series unveils a crucial truth. The health of our soil is deeply intertwined with nutrition, climate, and the sustenance of all life on Earth. For years, the rampant use of chemical farming methods has drastically depleted essential soil nutrients, leading to a decline in plant health and our overall well-being. These podcasts emphasize that nutrient-rich, high-quality food is the foundation of our mental, physical, emotional, and spiritual health. We address the critical issues of our diets being deficient in essential nutrients, a problem increasingly linked to the rising of mental and physical health challenges. The Wellness Crusaders not only highlight these issues, but also provide answers and solutions. Upholding the wisdom of Hippocrates, let food be thy medicine and medicine be thy food. We are committed to empowering lives, inspiring wellness, and offering solutions. We hope you will join our crusade. But before we get started, just a few disclaimers that I wanted to read. That the listener understands that the role of a health coach is not to prescribe or assess micro and macronutrient levels, provide healthcare, medical, or nutrition therapy services, or to diagnose, treat, or cure any disease, condition, or other physical, mental ailments of the human body. Rather, the coach is a mentor and a guide who has been trained and certified in holistic health coaching to help clients achieve positive, sustainable life challenges. We are not acting in the capacity of a doctor, licensed dietitian, nutritionist, psychologist, or any other licensed or registered professional, and that any advice given by the coach is not meant to take place of their professional. The listener, if they are under care of a healthcare professional or currently use prescription medications, the client should discuss any dietary changes or potential dietary supplements with his or her doctor and should never discontinue any prescription medications without first consulting his or her doctor. The listener understands that the information mentioned in our talks should not be seen as medical or nursing advice and is not meant to take place of seeing licensed health professionals. So today, I'd like to welcome world-renowned MD, PhD, nuclear physicist, and attorney, Dr. Richard Fleming. Dr. Richard Fleming is also the lead contributor to 10letters.org, which we will talk about at the end of the show. This series of talks with Dr. Richard will bring you zero cost to consumer information about science and information on helping you support your own immune system. And now what I would like to do is to introduce you all to Dr. Richard Fleming. Dr. Fleming, can you hear me?
I can. Can you hear me?
I can. Oh my gosh, I'm so honored once again to be interviewing. We've done a lot of podcasts together on a lot of really great subjects. But I have to tell you, this is our first live radio talk show on your Twitter account my Rumble account, and on mainstreetmediautah.com. So I'm honored again to have you as my first guest speaker.
My pleasure to be here. I know I'm interrupting, but you were talking about nutrition. These two books right here, these two books are nutrition books that I have from the mid 1800s that were written for physicians to read, to know, to understand, and to apply to their patients. And these books carried a lot of medical weight prior to the 1900s, when the American Medical Association essentially took control of medicine. But I thought I would show you that because this is the type of stuff physicians do get when they're in training. Sadly, I think too few are remembering to apply it for a variety of reasons, and we get into that or maybe over multiple programs. But I wanted to show your listeners to begin with that I actually have books like this that go into great detail, and I treasure these books. Anyway.
Oh my gosh.
My apologies.
I can't wait. It's one of the next conferences. You'll have to bring one. I'd love to be able
these are so old. I mean, these are the 1850s, and they are important enough. I would not carry these through the airport, just simply because nobody treats things with respect like they should in airports, and I would not. These are irreplaceable.
Oh, agreed on that. So I want to actually, before we get started, I wanted to show this book. It was a book that you wrote in, I can't remember if you said back in the
2004, I think.
And the name of the book is called Stop Inflammation Now. And I have to tell you, for all of our listeners, either watching us or listening to us, it is a staple. It is a must-have in every single household, especially right now where we're living with these stronger viruses. And it was amazing. I found it fascinating.
That book we were going to launch, and I had 2 meetings that were set up to review it with publishers, to get a publisher to pick up on it. And the meetings were scheduled for South Tower, September 11th, 2001, and they got canceled the week before because of an injury somebody had, or I would have been in South Tower on September 11th, 2001
thankfully
for that
you weren't.
book. Well, again, I think I probably should have been there to help people, but
well, you are helping people all over the world, so I thank you for that. But so we'll get started on some of our questions. So the body is complex, and there is so much we still don't know about it. There are a lot of truths, and there's a lot of lies. And I'm thankful that mainstreetmediautah.com has given us an opportunity to talk about the truth. So with this said, there's a few things I want to ask you, actually, a lot of questions. So what really is a cold?
Yeah, great question, because everybody uses the term differently. It's not a medical term, it's a lay term. And typically when physicians hear about it, we equate that with you've got a virus of some sort. But what it really means is that your immune system is kicked in. The first part of your immune system, the innate, INNATE immune system, releases chemicals in an effort to kill off things that are invading your body. And those chemicals, when they're released, cause a runny nose, elevated temperature, runny eyes, nasal congestion, cough from the congestion, the symptoms that you have when you get infected. So a cold is really the release of those chemicals, but that could be a virus, it could be a bacteria, it could be a fungus, it could be any of a number of things, but typically we think of it as you have a virus of some sort.
Okay, nicely said. So why don't we have a cure for the common cold? I know that the cold virus is caused by a bunch of different types of viruses.
Right.
And I've recently heard that there are over 160 different types of cold viruses. So why do you think there is no cure?
Well, there's a variety of reasons. Number one, there's no money in it. So big pharma is not going to expend that. But the reality is that these viruses keep changing from year to year, or sometimes several times a year, and they can exchange parts. So when you consider 160, you really have to start looking at the fact that you could easily have 10 or more of each one of those 160. And now the idea is, what are you going to do to cure that? Are you going to try to develop a vaccine that has all of those 160 times 10 possibilities in it and inject that into somebody? I mean, the overwhelming impact that would have on the immune system, not to mention the fact that many of those you're never going to see, you're never going to be exposed to. So we have a cure. It's called exposure. You get exposed, your body develops an immune response to it, and the next time you see that, it will take you less time to recover. But that's that cure. It takes that approach that nothing ever changes, and somehow we've seen everything that there is, and so therefore, we'll respond faster. But every time you get exposed, you're going to be symptomatic. It may not be much of a symptom, or it could be a lot of a symptom, but it's going to take that long for the what's called memory cells, that are the cells of your immune system, that says, wait a minute, I've seen this before. Here's what we do. Here's the T cells we need and the B cells we need. But you're never going to vaccinate somebody for all the possibilities, because every time you think you found the possibility, well, a new variant comes up, a new permutation or a shifting
Yes.
occurs, right? So it's a
Yes.
dog chasing its tail, is what it is.
Okay. Uh, so, how do you catch a cold?
Oh, okay.
Besides
With
for staying
baseball,
away
with
from
with
everybody and locking
with a
yourself in a
baseball
little
glove, yeah.
bubble.
Yeah, and you don't want to be one of those kids. I took care of one of those kids when I was a medical student, and they were in the hospital every day except 1 week of their life because they did not have a functional immune system. You do the things that your mom and dad probably told you to do a long time ago. Um, you don't cough and sneeze on other people, right? If you cough or
Right.
sneeze on your hands, you wash your hands with soap and water. I mean, I found it astonishing that we had to have jingles in the last few years to tell people to wash their hands long enough. And by the way, it's mostly the friction. So you put the soap and the rest of that, so you develop friction so that you just put friction on the skin, and that material gets knocked off by and large. You don't cough on people. Yes, you put a handkerchief or something over your mouth. This is where the whole masking thing came up, so that you didn't spread it to other people. And it was mostly the concern about coughing droplets out on people, because let's be honest, if a dry virus comes out on somebody, it's not going to stick. If it's coughing out on that mucus from those symptoms, that runny nose you have, it'll probably stick. And we saw all sorts of people demonstrate just how poor quality they applied to their lifestyle. And I'm not going to go after anybody in particular, but if something comes up, I'm going to say it. When I watched Anthony Fauci standing next to President Donald Trump, and he took his and Fauci took his mask off, shoved it in his pocket, wiped his face, and then took the mask out of his pocket afterwards and put it back on his face. Well,
Oops, I lost him. Oh, hold on. Technical difficulty. Let's see. Technical difficulties. Gotta love live streams. Can't hear you if you can hear me. All right. Well, we have lost him for a minute. And no, we don't have you muted. Stay tuned. We will be right back. Dr. Fleming, can you hear me? All right, for all of our listeners out here, we're just going to have Dr. Fleming log back out and back in. I guess that's the joys of going live. Let's see, he's going to log back in. So just to recap, we've already asked Dr. Fleming what a cold really is. More importantly, how do you catch a cold? And just a side note. So, oh, is that him? Let me bring him back in. There you are. We can hear you.
All right.
Gotta love live streaming. Okay, so I didn't hear,
Well,
we were talking about catching a cold, and I wanted to just add in there so you could add that even though our skin is our largest organ on the body, that the eyes, the nose, and the mouth are common entry points. You know, like you shake a hand or touch a door handle or touch something where the virus is, where a majority of the people is, and then they touch their face at some point. I can't even tell you how many Zoom calls I'm in, and I always see people with their hands or even like in their mouth, and even though they're at home, touch your face upwards of 20 times a day when you're on a Zoom call. So if you could just recap really quick on how do you catch a cold, and then make a comment on the eyes, nose, mouth, even though the skin is the biggest organ.
Hard to say you catch it with a baseball glove, but normally, if somebody has an infection, particularly, they'll passing or sneezing on somebody, right? I mean, there have been studies where they've looked at people who aren't coughing or sneezing, a large virus load, and they're top front of somebody, and the virus comes out. It turns out that that is to actually talk back to the view, pushes it back towards them to divert the course. Concern is when people are coughing and sneezing, and that's how the virus can go and stick on some person, will rub their face or spread, and any opening into the body for an infection to get in. One of the things that we with the skin is the body, and we emphasize, what does the skin do? It keeps the outside out, right? Which means it protects you from injury, from dehydration, or find one of those openings. Those they love the face and the eyes, the temperature, the heat, and that's what draws. So anything that allows the bypassing the skin is a way to think about it. There's only a few ways in: eyes, lungs, GI, you get in the body. and isn't even in the body, because the donut is so big and convoluted as being in the body, but it's outside the body. So you have to do things prevent passage from one person to a person, to do, hygiene taught you to do when you're a kid growing up. Sneeze
Right.
on people. If you're coughing, use a tissue or a Kleenex. As my kids are taught, put your elbow over. Don't. And then don't transfer it in front. Pet peeves, to be real honest with you, with the men, guys, and wash hands after they're in there. And told people that if you're coming up to me and reach your hand out to shake my hand, probably not doing now, because I don't know, clean your hands. And we come across all that we transfer back and
Hey, Dr.
forth.
Fleming, you're fading in and out. It's the audio. We can see you just fine, but we're only catching every few words.
And that is because I do have this up. Last you out, I'm hearing you very loud. So we'll try and continue. I mean, those are the things you do. Clean your hands, or school. If you're sick, don't spread. Nobody wants you to share what they have. A great place to be if you want to be exposed, or in a school where everybody, it's a great way to build up immunity but just staying away from other people when you're washing your hands and face and that.
Okay, so I'm going to try to recap since we were only
Sure.
catching a few words. Obviously, we talked about washing your hands, and it's the friction of the hand washing that is helpful. I know that my little 6-year-old granddaughter, when she washes her hands, she's always counting to 20, probably sometimes more. Sometimes I don't even see adults in the bathroom washing their hands, which is totally disgusting.
Right.
And I don't know if you've recently flown or not, but I got to tell you, there's so many people flying sick nowadays. But I will get to the next question, and hopefully we're going to be able to hear you a little bit on that. So we just recapped, how do you catch a cold? So the next question that I have, and I want to recap that too, that the eyes are a very common way for colds and viruses to enter. So I always say to travel with some type of a non-toxic, like hand wipe. I personally, for me, I like to use hypochlorous acid. I'll talk more about that downstream. I travel with it in a little because it does kill like a COVID virus if somebody does have COVID and they, are, forced to travel. But a follow-up question to that is, how long can the cold virus last on the hands when people don't wash, or on a door handle, or even on a plane seat?
Cell phones and kitchen counters and that type of the virus. And there are some hours. I remember back when was first detected point in time, and we were trying to sort out this live, and it really depends upon the virus. If you go to England, all the little parks that are established, a lot of people will go there and think, wow, neighborhoods. Many of those parks, because that's where they buried bubonic, and they know, and there's those bodies get dug up. Will that area be bubonic plague? So some of these bacteria some of the time exist, we know can lie hundreds of years. Most typically, we think between hours and days, and it just nobody has done a really good job for SARS-CoV-2 because what would you have to do? You'd have to have them cough on something to be able to take samples of it, and then you can grow it. And nobody is clean the toilet seat. If it's wet, you probably need to dry it. That type of thing. Hear you. I can't hear you, Laurie.
Your mic because your video is good. So maybe if you could just do us a favor because everybody's. Yeah, so if you could log out, I think it's like your mic is lagging because your video is excellent. So I don't know, maybe if you can start and come back in or use the computer mic to see if that's any helpful.
Let me think something else, okay?
Okay.
I'll be right back.
So stay tuned, everybody. Dr. Fleming is going to be right back. Again, streaming on the internet. Sometimes you have a little bit difficulties. Everyone always has them. So we're just going to try this again, and then I will have him go back to the question on how long the cold virus can last. And what I've heard in all the research that I've done is that a cold virus, and we're talking only about the cold right now, we haven't got to the flu yet, that it can last for 24 hours. And your skin provides you a certain type of barrier to protect you. But 24 hours. I don't know how any of you travel. I usually always travel with wipes. I'm a stickler on wiping down plane seats, wiping down the carts in the grocery store. I try not to use a handle when I'm opening a public place. If so, I'm trying to sanitize with something non-toxic, of course, my own hands. And here's the recap. 24 hours for a cold virus. So that means somebody sneezes, and it happens. Look in the grocery store, if you're walking through a shopping mall, people sneeze all the time, and they're not even covering their mouth. So that means wherever that is going, that cold virus is lasting up to 24 hours. That's a long time. So let's see. Looks like Dr. Fleming is trying to log back in. I apologize about that. There he is. Let's see if this is any better. And it looks like you have different headphones.
Or they're third time's charm. Can you hear me? Yes.
Oh,
yes.
Well, they look like it's either you have new headphones or they're white earrings. We can hear you just fine, sir.
Okay, perfect.
So,
a little fuzzy on this.
Okay. And then, Leighton, I can hear you just fine. The listeners, if you could just let us know if you're able to hear him just fine. So, Dr. Fleming, I just recapped that I heard it was up to 24 hours that a cold virus can last on a surface. And I know that when I'm walking through the grocery store, most people are going to sneeze, but it's amazing how many people still aren't covering their mouth. But to get to the next question.
Okay. I was going to say, it's a sad reflection to where nobody bothers to take and do, which is simple. Did you hear that?
No. Barely.
No. Can you hear me?
We could see you really good, though. Yes. Okay, Dwayne is saying he can hear you.
Okay.
Okay. Okay, do you want to just test into your mic?
Testing 1, 2, 3. Is it coming through?
Yes, I can barely hear you. Let me just ask a couple of our listeners. Let me turn my
You're
mic up.
blasting in
Okay,
my
do you want to
ears.
try that one more time?
Is that better?
That
Yes.
is better, yes.
Okay.
Gotta love technology. So the next question is, and hopefully we were not going to have any more technical glitches, but so how small is the cold virus? Like a micron, and a micron's like the side of a credit card, which is about 200 microns thin. How small is it? And do wearing masks, I know that it's helpful when the person is sick, but do wearing masks help prevent someone like me from getting a cold virus?
Um, so the size of the virus is really virus. It is, like SARS are range anywhere between 60 nanometers, so 80 to 120, small, about 300 microns, and it is about 6,000. So it tells you just how small. Most of the time, masks that people were wearing, very good job of catching, if you were coughing and sneezing, obviously it was catching that. And catching it and holding it away for infections more than anything else. Can you hear me, Laurie?
Yeah, can you bear, it's still cutting in and out. So I heard 300 microns, and then I was choppy on the masks.
So, you know, for small, they're about 300 blood cells or 6,000 nanometers. Perspective on just how small, and water droplets. The sizes of most masks are passage of the virus. As a physician, if I'm working procedure, I'm going to wear a mask. I don't want to transmit anything. You really worried you don't transmit something to me. My respect as and just making certain that happens to you. Masks did not dry if there was no going along with it. But if it was into their mask, just putting a breeding ground problems.
Okay.
Did you get?
It's still cutting out now.
Yeah.
It's still cutting
I'm
out
sorry.
for some reason. Now I don't know if it's technical difficulties like on the interconnection on your side. It's weird because I can see you just fine.
Right. I mean, I have microphone systems all the way in, so, and I'm hearing you on my end. I just under the direct microphone and probably have.
Can you try just the computer mic, maybe your laptop mic?
Yeah.
Okay.
Yes. Can you hear me?
I can hear you. Are you using the computer mic? All right, hold on, everyone, again, just one more time as we try to work our way through the technical difficulties. Or let's see where we're going with this. Can you do a test?
Are you able to hear me pretty clearly with that?
No, we're only actually catching every few words, and the information is so like important. And actually, Restream is saying it's excellent for the connection.
Minutes, and I'm going to try one more thing, and I'll be right back.
Okay. All right. So hold on again, listeners, and we will be right back. And again, we apologize about that, but this information is so important. We just need to make sure that we're getting it into the hands of all the people that are listening from Utah and any of the surrounding states. I know that I've got many people on the East Coast that are listening as well. So we just need to get the hands delivered. This is information that is truthful. It is not censored. And there could be possibilities that you may not hear any of this information from your doctor. And so that's why it's important that this talk gets out. So stay tuned, and we will be right back.
Can you hear me? Laurie?
Yes, we were able to hear you.
Okay.
Oh, it
let's see
actually
if I-
sounds better. And I always
right.
enjoy looking at your wall of licenses and certifications. It's
Yeah.
so, okay. All right. So, you know what? Let's just start over with that last question for our listeners.
Sure.
How small is a cold virus? I heard, so a micron, just so they know, is about the size of the side of a credit card, which is about 200 microns thin. So how small is it? And then for the person who is not infected, does wearing a mask help prevent them from getting a cold virus?
So, right. So viruses vary in size depending upon which type you have. I mean, the SARS-CoV-2 viruses were anywhere between 80 and 100 nanometers, and a nanometer is 10 to the minus ninth meters, so extremely small. And that's in contrast to like smallpox, which is 300 nanometers, and a red blood cell is 6 microns, so it's 6,000 nanometers. So it gives you perspective. Wow. A dry virus is probably not going to be stopped going through most of the masks. I mean, what an N95 mask means is that 95% of the material that it's typically exposed to gets blocked, right? The typical masks that we wear, those little things that all of you started wearing, doing surgery in your car as you were driving down the street, apparently is all I could figure out. If you're coughing or sneezing and it's got a water droplet, it's gonna stop it. But by and large, it's not going to do anything really for dry viruses. The only question is, why would you have
dry viruses. If you're not coughing and sneezing, you're probably symptomatic. And so there was a study that was done out of Johns Hopkins, and it compared hundreds and thousands of studies that were done, of which only a half dozen or so or dozen had any value. And it showed there were two things that made a difference in transferring viruses, the SARS-CoV-2 viruses, back and forth. One, better hand washing.
Or hand washing altogether.
Yeah. And number two was, if you were sick, staying away from other people. Now, again, my mom and dad taught me that when I was a little kid. And I'm not certain if that stopped being taught, but that accounted for 90+% of the benefit. People said, I'm sick. I'm not going to cough and sneeze on other people. Let me stay away. And they cleaned their hands and their face and did the things that they should to prevent transmission. So there's really no good studies that showed that the masking did anything. And I love the term flattening the curve, because as a physicist or a scientist, just in general, flattening the curve doesn't mean changing anything. It just means spreading it out longer over a longer period of time, but you don't change anything in the end. It's the same volume or number of things. So yeah, we flatten the curve, great, but we just spread things out as a result. And I think we spent a lot of money and a lot of time to reinforce what my father with an 8th grade education and my mother with a high school education already knew long before, NIAID was actively involved in any of this.
Okay. That's quite interesting. I love how you explained too about the size of a blood cell. So when someone is contagious,
Mm-hmm.
and when do they become contagious? I've read that it's 5 or 6 days after your worst symptom. So maybe they're exiting the contagious portion, but if you're still tired, you're still groggy, you're still coughing, etc., you can still be symptomatic. So when do they become contagious?
Yeah, you become contagious, number one, as soon as you get exposed to something, you have it, and then you can spread it to somebody else. All right. This is this asymptomatic carrier phase. You don't become symptomatic until 3 to 5 days after you've become infected with something, because that's how long it takes for your innate immune system to start releasing those chemicals to produce the symptoms. And then I tell people that as long as you're symptomatic, 72 hours after your symptoms stop, you're probably not contagious anymore. That is to say, you have nothing that you're going to be spreading to other people. And it's important to kind of give that lag time and understanding time. In medicine, we have a lot of things that we use to listen to see if you have a pneumonia. One thing is a stethoscope, and another thing is a chest X-ray. And a good physician can hear pneumonia 72 hours, 3 days, before it ever shows up on a chest X-ray.
Wow.
And similarly, at the end of the infection, when we don't hear a pneumonia and the chest X-ray still shows one, that's because it takes 72 hours for the fluid to resolve in the lungs. But when we don't hear one, you're over it. Your body's just cleaning up the mess. So there's this lag time that appears that if you're a good physician, you can hear something before it shows up on the tests, and it's gone away before the tests show it. And the same type of thing happens when you're symptomatic. Give it that 72-hour lag time. In infectious diseases, 72 hours turns out to be a critical kind of bookends to what's going on number to use that we've seen for decades, many decades, for me now, for medicine of of a nice end cap to put on that to say, okay, it's been 72 hours, I'm good.
Okay. All right. And then before we move on to the flu virus, I just want to make this is my personal comment. So I recently flew, and there's so many people who are on the flight sick, or they go to work, or they go shopping, or they're going to school sick. And they have a hard time understanding that it just keeps spreading what's going around. So it's actually other people are getting sick. And honestly, I am not really sure in this day and age if there is anything that we can do about it. I mean, people have to get places, people have to go to work, but I really truly believe that's why all of this continues to spread. But let's move on to the flu virus. Now, I know there's many different types of flu viruses, and then the different categories of the flu virus. There's a type which is the most common type, which is B type and C type flu influenza viruses, and that they propagate from host to host, host meaning us as a human.
Right.
Even though they don't have a brain, these viruses, they certainly have viral intelligence, and they always outsmart humans because they have been around since the beginning of the time. So can you start off telling us, one, what is and was the H1N1 virus?
Right. So a lot of people have heard about spike protein. Obviously, at this point in time, it's a protein that sticks out from this severe acute respiratory syndrome coronavirus, number 2. It's a protein. Influenza viruses, of which A and B are the two that are the most common, and then C is one that has been relatively recently kind of detected, have a couple different proteins. One is called hemagglutinin. You know, we frequently talk about this inflammothrombotic response, and everybody just talks about inflammation. Well, hemagglutinin means blood clotter, okay?
Okay.
There are 18 versions of hemagglutinin, all right? The
Wow.
other part is called neuraminidase, and it is something that there's 11 types of. That's the N. The hemagglutinin was the H. And it dissolves sialic acid components. And you may have heard me talk about this before, because that sialic acid receptor raft is the NER5AC raft of the cell that the glycoprotein 120 part of the SARS virus attaches to. So these are enzyme systems that cleave these sugars, these glycolytic areas. So you have 18H and 11N, right?
Okay.
You can mix that around. Think of how many permutations that is, right? So the Spanish flu of 1918 was H1N1. But there are 18 and 11 choices to choose from. So that was just one version of that influenza virus that went around. And it turned out to be extremely effective and harmful to people. It was infective and people responded poorly to it, with a lot of inflammation and blood clotting, as I've beaten to death since 1994.
And that goes back to the inflammothrombotic disease that you're
Right.
so well known for. Okay.
Well,
all right.
Sometimes.
So how does the flu virus affect the body? I've read that the flu virus can only exist on surfaces for 2 hours, recap to the cold virus that exists for 24 hours, and then starts to die off. So how does that flu virus affect the body?
Right. So, you know, and the cold virus that you're referring to, like rhinoviruses and respiratory syncytial viruses, and those tend to be more durable. That's why they can last longer. These viruses, one of their weaknesses is they really need to be inside a host to find a living cell to survive. So they have this great adaptability at infecting people, but they're not so good on surviving on their own. So that's the first critical thing. And then always you have to ask what the major route of getting into the body is, which is typically respiratory, and it tends to favor infecting the cells inside the lungs because of, for lack of a better way, a lock and key mechanism. When these H and N components come into the body, these proteins tend to recognize cells in our lungs, and that's what allows them to set up housekeeping and cause symptoms. So when you think about the lungs, what do the lungs do? Well, they allow us to bring in oxygen and blow out CO2. So if there's swelling and clotting going on, we have breathing problems, we have difficulty getting blood to the heart and out, so we can have fatigue because the blood's not well oxygenated and there's congestion. So you tend to get those two things. And then most of the time when the innate system gets activated, a couple of the chemicals, interleukin-1 and interleukin-6, when they reach the hypothalamus, because they don't just stay at the site of infection, when they get to the hypothalamus, they trigger an elevation in temperature, and that's why you tend to get a fever. And so while the symptoms you may think of them as going where the virus is, those chemicals get all over the body and they have an effect elsewhere in the body. And in this case, the hypothalamus in your brain causes changes in your body to shrink up blood vessels and to increase the heat of the body in an effort to try to kill off, in this case, the influenza virus, but it could be SARS-CoV-2 or rhinoviruses or any of a number of other viruses.
Okay. And you mentioned fever.
Mm-hmm.
So can you explain to our listeners what exactly is a fever?
Well, technically, it's just an elevation in temperature above and beyond what somebody normally has. And older people tend to have lower body temperatures to begin with. So it's higher than is normal for them. So a normal body temperature of 98.6 degrees Fahrenheit orally, which changes depending upon where you take it, is normal for a healthy middle-aged person. But for somebody who's 90, if they're running 98.6, they have a fever because they normally run 1 degree lower than that. So it's an elevation in temperature. And the reality is it's trying to kill off whatever the problem is. But if that temperature goes up too high, for lack of a better way of stating it, can actually cook your brain, right? And that's why we worry about people having seizures with elevated temperatures and meningitis or an infection in the meninges, the lining surrounding the brain, because of the potential harm. And when that inflammation and blood clotting occurs there, what you see is the brain acting up, and you see things like seizures, unusual brain activity, right?
Okay. So just a couple of questions for parents that are listening. Mm-hmm. How should parents control what's the recommended? How would parents control a fever in a child, and what about the babies?
Right. So it's mostly a matter of difference in the types of medications that we give if you're trying to lower the temperature. I mean, you can do some things. When we have somebody who's critical in the hospital and they are, quote, burning up, and we can't get the temperature down, there are actually ice baths that we will do to try to save somebody's life.
Right.
But I don't recommend that parents do that. I mean, that there tends to be some danger inherent in doing that.
Right.
You wouldn't normally take your baby outside and throw them in a snow pile, right?
Right.
Because you can't control. And then what do you do if the temperature comes down too fast to get that temperature back so they survive, right? So the medications are different because in children and infants, if you give aspirin, you can get Reiss syndrome, which is a phenomenon where they start to have an allergic reaction and problems with blood vessels leaking, and that's not good. And so way back when I was a kid growing up, they gave aspirin to kids, right? But by the time I was a medical student, we recognized this problem, this Reiss syndrome. And so we recommend Tylenol, children's
Okay.
Tylenol, infants
Right.
Tylenol. If that's not doing it, we'll sometimes recommend alternating it with Motrin or non-steroidal, which doesn't tend to cause Reiss syndrome. And those two
Okay.
combined, alternating at the dose, and and this is why they always throw it back on the physician. The smaller the human being, the less medicine they need, and you can't take it out once you put it in. You can always
Right.
add more, but you can't suck it back out
Right.
miraculously, So, it's important to know and dose by the weight of the infant or child.
Okay. And so to recap for all of our listeners who are parents, we want Tylenol and Motrin over aspirin.
Oh, absolutely.
Okay.
Yeah.
So now let's switch over briefly to talk about the flu shots. So
Okay.
the flu shots, from my understanding, really is kind of treating last year's or yesterday's flu for a specific strain, that there's no way that anyone, any big pharma company would be able to create a flu shot that would be able to protect them from next month's strain. However, most pharmacists and some doctors don't really talk about this. They don't talk about the adjuvants, which are the extra ingredients that they're putting in to open up the cell wall, things like heavy metals like aluminum, thimerosal, mercury, or anything else that is going to open up the cell wall. And I think in the state of California, that they are up to over 60 different types of shots and vaccines for these children who haven't really developed an immune system yet. But why doesn't the medical world talk about, first of all, the harmful ingredients in them, like these heavy metals that are dangerous to anyone's immune system, let alone a child or a baby, and give them informed consent?
Well, I think there's a couple reasons for that. First off, when I trained in the dark ages in the early 1980s, we didn't have that many vaccines. And I have seen measles and rubella cases from consequences of people getting those infections real time. We didn't give as many vaccines. One of the things that we saw with these genetic vaccines that were being given by Pfizer, Moderna, and Janssen for SARS-CoV-2 is it actually changed the type of antibodies that people were making. And one of the questions I've raised is it the genetic vaccines? Is it the frequency of the vaccines that we're giving people that causes this shift? Because instead of seeing IgG antibodies, and there's 5 different types of immune globulin, that's what the IG stands for. There's A, G, A, M, E, and D. Instead of making IgG3, which is helpful, people getting these repeated vaccines are making IgG4. And IgG4 is what the body does when you have an autoimmune disease, and it thinks, well, this is part of my body. And it's also a way that cancers get by your immune system, because IgG4 doesn't stop cancers, and the cancers can use that to their advantage. So one of the questions that I've raised is it the genetic vaccines, or is it the frequency that we're giving vaccines, that we're doing it so much that the body's immune system is going, well, wait a minute, that's not something foreign, that's part of us, because we're seeing it all the time. So I think there's a real question that has been raised here, not only for the genetic vaccines, but for the frequency of these vaccines that are being given. And I will tell you that honestly, physicians by and large, with everything going on, there's a certain amount of trust that we're supposed to be able to have in big pharma making these products for people. I mean, it's come to the place where, unfortunately, sadly, a lot of questions are being raised by the medical community now of, wait a minute, the FDA is pulling twice as many drugs off the market every year as it's putting on. What happened to the process of making sure these drugs were safe to begin with? I'm not talking about vaccines. I'm talking about a lot of medications that get used. So medicine right now is dealing with the fact that, wait a minute, we're supposed to know which drugs to use and which ones to prescribe. And you people were supposed to be doing your job to make sure that the drugs we were given were safe. And I think we are sadly being confronted with all of these problems. I mean, these adjuvants, these things that irritate the body, that do damage. We've known that mercury, we've known that aluminum causes that, but the vast majority of physicians weren't being told that this is in your drug. We in our training, we don't have the time to sit down and read through every chemical and every drug that we prescribe. We are of the naive perspective, I guess, that, wait a minute, the FDA was supposed to regulate this, right? What happened to the FDA? Well, I can tell you what happened to them because I watched them approve these 3 genetic vaccines, and there wasn't a single question about there's no immunology data, there's no data on a variety of things. If you did the statistical analysis of the vaccines, there wasn't a difference in the number statistically, scientifically, between the people who got sick with COVID or died who got vaccinated who didn't. Yeah, the numbers were different, but scientifically, statistically, they weren't different. So, and I listened to those sessions and thought, well, there's, 8 hours of my life I'll never get back. And they didn't ask the very specific questions. So by and large, I would say that sadly, physicians would not normally think, when you're in the business of taking care of people, that you would intentionally put something into a drug that you're making that you then say, doctor, prescribe this to people, and it's toxic. I mean, this is a reality that physicians are beginning to deal with, and the old issues about Alzheimer's and aluminum and problems with kids. Some of that data was questionable, some of it wasn't. And Big Pharma used that to their advantage, I think, to seed doubt and to raise questions. And I've told people since day one, I tried to stay away from infectious disease. I thought that Fleming's had already done enough for infectious disease, Sir Alexander Fleming and penicillin. And the theory that I put together in inflammothrombotic diseases brought infectious diseases in there. I didn't think I was going to have to go babysit Big Pharma and the FDA to make sure that they were doing their job. But quite frankly, at this point in time, based upon how poorly they did with the Pfizer, Moderna, and Janssen vaccines, my level of confidence is a little bit shaken, to say the least.
Okay. So let's switch for a quick minute, and then I'm going to come back to a couple of other questions that I'm curious about. So there's 2 different types of the immune system. You have the innate immune system, which is what you're born with, and the acquired or adaptive immune system, which is what you acquire, throughout your lifetime. You get sick, your body creates antibodies, you've got the memory cells, it remembers it. So can you give us some basic information on these 2 different immune systems?
Right. So you're born with both. You're born with, because your innate system comes from your T cells and your thymus gland, and your adaptive humoral, the other one you referred to, comes from your B cells, which are basically in your bone marrow. So you're born with both. The reason why there's a layering is that lower species animals don't have antibodies. They just have the innate immune system. And so that's why they're referred to differently as adaptive, because
Okay.
it's the higher species that have the adaptive antibody system. So you're born with both. The T cells respond faster. It takes them 3 to 5 days. They're the first part of the system that kicks in. And it takes the B cells, the antibody producing cells, about 7 to 10 days. And that's
Okay.
why, by and large, most people who get viral infections have viruses that last for 7 to 10 days, because it takes that long for the antibody system to gear up. Now, in each case, they then make memory cells. So you have T memory cells and B memory cells. And, when Fauci was first talking about the vaccines, he was doing a lot of talking about the antibody, B memory cells. And
Right.
then behind the scenes, what the general public didn't know is that the people that I knew that were at NIH and Collins and some of the other people began pointing out, wait a minute, our data says it's probably the T memory cells that we want. So there was this switch in the narrative that he provided people, as the people around him, and he's the guy directing NIAID, the people around him were pointing out, well, Dr. Fauci, it's not the B memory cells we're really going for, it's the T memory cells. And then you heard the change in the narrative. Did that answer that question?
That did.
Okay.
Okay. So now that we've talked a little bit about the two different types of immune systems, the differences between the cold virus and the flu virus, can you give us some information on the RSV virus? Because currently, right now, what I'm seeing is a huge uptick in RSV, and it's kind of really bad because it is lasting 2 or 3 weeks, and it just seems that it is so strong.
So, yeah, respiratory syncytial virus. So syncytium is anytime there's more than one nuclei in a cell. So cells that merge together. So it can be like the placenta, or it can be like the conduction system of the heart, or it can be like the respiratory syncytial virus. Has been around for a long time. And so what I'm not clear on is what they're doing in the hospital. I mean, I've taken care of kids. I moonlighted, I worked emergency rooms a lot of years of my life when I was in training to help pay bills while I was in training. And we used to see RSV kids all the time. And we would give them Salumedrol or dexamethasone. And we knew exactly what dose based upon the weight. You gave it to them. It was a muscle injection. And then you dealt with any breathing difficulties with nebulizers to open the airways up. And we would have to admit kids in the hospital frequently. But once you do that, once you give the steroids that activate the immune system and knock down the inflammothrombotic response, and then you open the airways up, they tend to recover. My concern, although I don't know this for a fact, because I haven't been running in to see what they're doing with pediatric kids with RSV, is that if they're not any better than they were with SARS-CoV-2, giving steroids, the right doses of steroids, not these mini doses that they were giving, which are lower than we would give a COPD patient who would come in. If they're not doing any better job than that, I can see why they're having problems. And if they've lost that skill set, somebody needs to remind them of how we used to treat RSV.
I wish that there could be some of those friendly reminders going back to kind of the olden days in medicine, where honestly they were still teaching the right type of medicine. But
well, it really pays to do your homework. I mean, I remember a case when I was a student, and teams were divided, and we did rounds on a patient. They couldn't find the infection in the patient. They'd done blood tests, they'd done sputum, they'd done chest x-ray, they'd done urine, they'd done all that. And the attending, and I was a medical student, a third-year medical student, said, okay, what else do we do? Where else could it be? And everybody gave their guesses, and I kept trying to raise my hand. He says, no, just the team taking care of them. So the other half of the group. Okay, they didn't get it. So I finally raised my hand. He says, okay, Fleming, what do you have? I said, you do an ultrasound and you look behind the gallbladder liver because that's where there's an abscess. And he said, he said, that's right, but how did you know that? And I said, well, they have really good old textbooks that from people who've already gone through this stuff before. And in those textbooks, it says, if you can't find a source of infection and you've done these things, it's probably an abscess behind the liver near the gallbladder. Do an ultrasound. And we did it, and that's where it was. So learning and reading from the people that you think you're smarter than, who laid the foundation of this stuff, is a heck of a good way to become smarter.
Okay, nicely said. I want to switch over to how do we strengthen our immune system using supplements like vitamin C and vitamin D. But before we go there, can we give a brief explanation? How does the COVID virus differ from the flu and the cold virus?
What I think you're going for is how do they get into the cells?
Correct.
Is that
yes.
right? Okay.
Yes.
So, everything has a different lock and key mechanism. And so for the SARS-CoV-2 viruses, remember I talked about that neuraminidase, the sialic acid receptor,
Yes.
and it swings in there first, and then it brings it into contact with the ACE2 receptor. And then there's the furin cleavage site that divides the spike protein, and then the TMPRSS2 that brings it in to the cell. So there's a series of things. But I think what you're referring to is the ACE2, the angiotensin converting enzyme 2 receptor
Yes.
that everybody has gotten to hear about. And there's really 3 different types of those. One is what's called MASS-R, and that tends to promote cancers. One is angiotensin 2, AT2R, and then AT1R. So AT1R is the angiotensin 1 receptor, is the ACE2 that you normally think of. And what it does is by coming into the cells and activating that, it causes blood vessels to narrow, it causes inflammation to go up, and it causes blood clotting to occur. If you activate the other one, it causes the exact opposite, right? Okay. So there's always this balance, and this particular one activates the one, AT1R, but we've been calling it ACE2 because your listeners probably thought that when I began explaining, oh God, now he's talking about 3 different things. Can't we just have a name? And so ACE2 is what it's typically referred to. It's activated. It's the one we think of. It causes a narrowing of the blood vessels up, blood pressure to go up, the temperature to go up, all of those things. They can cause high blood pressure. And so where most people have heard about it is we have medications that can block that. They're called ACE2 inhibitors or angiotensin converting enzyme inhibitors, depending upon where they're working at. And they block that receptor so you get relaxation. And they are found all over the body.
The ACE2 receptors, correct?
ACE2 receptors are found all over the body.
Right.
Because they have this effect on blood flow. What's the number one place that you find them in the body? Blood vessels, right? Cardiologists like myself ought to be able to answer that question for you. Where's another place that they're really prominent?
Nasal
the ovaries
passages?
and testes. The ovaries and the testes. Okay? They're present throughout the body, but they're also heavy duty because it's important to keep the temperature, which is affected by blood flow. Remember the hypothalamus affecting the blood flow.
Yes.
It's important to keep that blood flow the right temperature and the right amount for the eggs and the sperm to develop to have a chance. So it's an extremely delicate balance system in the ovaries and testes, not to mention the rest of the body for blood vessels.
Okay. Thank you for that. So I want to talk a little bit about the RDA. So they establish the minimal amount of a nutrient that is needed to prevent disease. As an example, in the case of vitamin C, The RDA of 75 milligrams a day means that the majority of the population, 75 milligrams is a very minimum amount necessary to prevent scurvy or scurvy associated disorders. It doesn't mean optimal amounts of vitamin D. Why has this not changed since more people are getting sicker, and actually the uptick from, getting COVID and, the late 2019, early 20, but our bodies are stressed, children are sick, our cells require more vitamin C's because it's rapidly used up even under stress. So why hasn't it changed?
Yeah, that's like a patient coming into me and saying, "Why didn't my doctor think about this when you did?" And I never have a really good answer for that type of thing. I have a lot of answers, but nobody likes them. So part of what we know about the RDA, the recommended daily allowance, right, is based upon research that was done many, many decades ago, and they were only done because for the vitamins A, K, E, and D are fat soluble. So it's easy to get too much of these vitamins inside of your body because they will store up in fatty tissue like your brain, your heart, and they'll cause problems. So the work that was done at a point in time where they were finding neurologic problems, heart problems, eye problems, vision problems from excess fat-soluble vitamins like A, K, E, and D. So they labeled what the dangerous levels were, and they kind of put a recommended don't go above this. And at the same time, they kind of poorly collected data on the other because there really weren't bad side effects to the water-soluble vitamins, vitamin C being one of them. And some of the research that was done on vitamin C was all over the place. And so let's briefly look at that. Any water-soluble vitamin is basically going to be excreted out of the kidneys when you get excess. So if you're consuming more, your kidneys dump it. And here's that 72-hour number again, that 3-day thing.
Right.
It takes about that amount of time for the kidneys to catch on and say, oops, we have too much, let's dump the extra. Or wait a minute, they cut back, let's retain it. And so a lot of the misinformation about the benefits of vitamin C was done because some people would say there was a benefit, some people would say there wasn't. And it really amounted to a few days difference, which had to do with the kidneys dumping out the extra. Because instead of saying, well, wait a minute, 72 hours, I think maybe we need to up that dose again. It's not going to become toxic because it's water soluble. We need to increase the dose because now what the kidneys are doing is dumping it out as fast as it's going in. And so the data was not very consistent, sadly.
Okay.
And so what you end up with is we have data for excess toxic fat soluble vitamins. We have lousy data for the water soluble vitamins. And it was kind of like, well, this is kind of what the general public has. So I guess this is our recommended allowance, give or take a little bit. There hasn't been any real research on it because there hasn't been any money benefit to the companies that would do the type of research, right?
Right.
And even with vitamin C, one of the things that we've talked about is that just because you're calling it vitamin C doesn't mean you have the same thing. I mean, there's really two types. There is ascorbic acid, which is an acid, right? And we have your favorite, right? Which is
sodium ascorbate.
Sodium ascorbate.
Pure C,
right?
sodium ascorbate,
right?
vitamin C.
Right. So one is an acid, ascorbic acid, and sodium ascorbate is a salt.
Right.
And they behave differently. They behave differently in the cells. The cells are more adapted to taking up the sodium ascorbate, just like sodium chloride. The system is set up to work with that, where the ascorbic acid is really an acid. and does not get taken up quite as well. Okay. And, and then there's the discussion about wrapping up in a lipid nanoparticle, like the vaccines, right? And I've never really understood the argument for taking a water soluble vitamin or anything and wrapping it in a fat soluble coat and thinking that that was a good idea. I mean, doctors get enough criticism as it is. And then I listen to somebody say, well, we'll take something that's water soluble and we'll wrap it in a fat. Well, how do you expect that that's going to be taken up where it's supposed to be when, if your body's functioning like it should be, it's saying, where's the water soluble vitamin at? So that adds to it. And then there's this attitude, that outside of antibiotics, to be real honest with you, we don't tend to have this, let's use it for a while and then dump it. Some of the chemotherapies we do that with, but I had a lot of patients that I've dealt with in my life that I will start on a medicine to buy time with the hopes that we can adjust their diet and lifestyle to get things under control so I can then taper back off the medication, which I thought was my job. But by and large, we don't tend to think in terms of, okay, we need to adjust. Let's adjust up, let's adjust down, and when you have something that is affecting your immune system, you need to look at yourself and say, okay, what can I do to augment or improve the health of the person? I mean, we can give you mucolytics to thin out mucus, right? We can give you antipyretics, things to bring down your temperature. We can give you fluids to help thin things down. We should be able to say, well, wait a minute. The immune system responds very well to, okay, maybe we need to watch vitamin A because it's beneficial. We know the B vitamins are extremely helpful with the immune system. We know that, I mean, you don't even have to do anything but know the alphabet here. We know the C vitamins are very helpful with the immune system. We know the D vitamins are helpful. We know the E vitamins are helpful. So we should be taking that same approach. I would argue that when we get into these processes, and the same thing's true with cancer patients. I mean, you listen to me give several talks where I showed that if you added high dose vitamin C, 20 grams, I'm not providing medical or legal advice here, people. So I'm just giving you an example to normal treatments for cancers. Many of the cancers that were resistant to the treatments responded in the presence of vitamin C because it changes enzyme pathways within the cell that are beneficial for dealing with the cancers, and it helps the immune system in helping to deal with the cancers, right?
Right.
So,
okay.
But it is a process of saying, well, wait a minute, maybe we need to address this. And the FDA would probably say, well, we don't address vitamins and minerals because we haven't done that and you can't make health claims from it. Okay. And you don't make claims about toothpaste either or preparation H, but you do tell people not to put preparation H on their teeth because idiots have done that, right?
Right.
So I don't buy that as an excuse. And again, it's kind of going back to those books that I showed you. This data has been talked about. And one of the things as a scientist that I do is when you get conflicting data, you say, why would the data be conflicting? What's different about the scenarios we're looking at that in one instance it works and another one it doesn't? Because it's usually what you think of as mistakes in doing research that's really science teaching you to be a better scientist and or physician. Is it's trying to teach you what the answer is if you just look for it.
I like that. And I want to recap that for our listeners, especially if there are like any medical doctors. So you recently spoke at the VCICI conference in Clearwater, Florida on vitamin C. And it was put on by Lior Scher with Pure C, which is the sodium ascorbate, which is actually my favorite vitamin C based. And there's a lot of controversy, I mean, on the liposomal. because you just explained that. You're taking a vitamin C and you're putting it into this package that the body and the vitamin C receptors don't understand. So for those of the listeners out there, and if there are any medical doctors, I would highly really suggest going to VCICIC, because it is the only vitamin C conference that I know that exists in the United States. So I just wanted to recap that. But let's talk, we're getting short on time here, so we're going to go
Sorry,
to...
I think part of that was the audio trouble, but we'll
Oh.
come back at another time if you like. So
Okay. And then, so how does vitamin C help COVID patients? But first, and I know that you mentioned inflammothrombotic response
Right.
disease. We've talked about that several times. But how does vitamin C help COVID patients? And does it help with the cold virus, the flu virus, and the RSV virus?
yeah, it actually helps with all of those, and it does so with probably a dozen or more pathways that activate the white blood cells that are responsible for responding to infections by helping to maintain the integrity of the blood vessels, because too little vitamin C is associated with the little red dots you see on people's skin where the blood vessels tend to be porous. It can help in the production of dopamine within cells to help deal with stress. So there's a dozen different ways in which, vitamin C can help the immune system. And if you provide the nutrients, the precursors to the cells, they're better able to function, right? I mean, one of the comments I made to people that I've dealt with who've been hospitalized with, quote, COVID, unquote, is many of them weren't getting fluids, they weren't getting nutrition, they had no social interaction. And my comment was, when was the last time you heard somebody tell you that malnourishment, dehydration, and isolating somebody was going to make your patient better? And yet, if you don't provide the precursors or the nutrients for a system to work, in this case, the whole body, but also vitamin C for the immune system, along with B, C, D, E, and A vitamins that all play different roles. I mean, there's only one thing that vitamin C doesn't do, and that has to do with T helper 2 cells. But every other aspect of the immune system, it augments, right? And the more it's available for the cells, and this is where the sodium ascorbate version, knocks out the ascorbic acid hands down by making it available to the cells. The more available it is to the cells, the more those cells are going to be able to do their job. It's like having a car. If you don't put fuel in the car, it's not going to run very far. If you put the wrong fuel in the car, it's going to sound bad, right? Same concept.
Okay, and then I might have spoke about how I said VCICI, so I want to clear that up because it's really important to know. It's VCICI, or people can go to pur-c.com, and that is the sodium ascorbate that we were talking about. And I'm just going to tell you, when I got COVID a couple years ago, I went right to the Pure C, and I literally had COVID for 2 hours. So it was my saving grace on that. But now, before I ask the next question, I want to read just a couple of sentences from your book, Stop Inflammation Now, because I'm personally still seeing this. And so you, on your first couple of pages in this book, you printed, "We weren't working together, and no one wanted to credit their colleagues with anything. So researchers working with cholesterol ignored the work on homocysteine, which is an inflammation marker, a very important one. And the homocysteine people ignored the work on fibrinogen, which is also equally important. The fight to determine who was right took precedence over finding the truth. And I have to tell you, it's still happening today. And it's so aggravating for people like me who are searching the truth, for other doctors who are out there talking about the cold or the flu or the RSV or the COVID, that they're not all coming together on one big team. And I just wanted to get that out there because I think it's so important for anyone listening. And listen, we both have a lot of friends out there fighting the good battle, but I think it's time that you put down the gloves and that everybody comes together. It's a team and people are still dying. But right now I want to switch over to vitamin D before we wrap up. So let me just ask you this question. How vitamin D is produced in the body, but due to the lack of sunshine that most of us no longer get, due to spending longer times inside, taking a supplemental form of vitamin D has to get converted in the liver if it's not the active form. So, but none of the clients that I'm working with didn't even know that. So can you tell me what the best form of vitamin D is? And is K2 needed to get vitamin D into the cell?
So there's, it's kind of like angiotensin 1, angiotensin 2. There are a series of enzyme steps that occur in the production of something, and vitamin D is 1,25-dihydroxycholecalciferol. Okay, and I can say that because I thought it was important enough to learn when I was a medical student. That's the one that's actually the active vitamin D. So when you have that, it's not that you need vitamin K or anything else to do that. That's the active form. That's what your body is trying to produce. Again, it's a fat soluble one, so our data is not as good, I think, as it should be. You know, it got addressed 30s, 40s, 50s when there was concern about toxicity with people getting too many vitamins and people were being sold whatever without any thought about the consequences. You know, more is better. I mean, that's kind of the aspirin model, right? I mean, when I tell people to take an aspirin, I say take 1 or 2. It says 1 or 2. And I think that that means people think that 5 or 6 is really going to be great. So we don't have a lot of really good data on that. I don't have a specific brand, but if it's 125 dihydroxycholecalciferol, that's the active vitamin D that you're looking for.
Say that 3 times real fast.
If it's 125 dihydroxycalciferol, if it's 125 dihydroxycalciferol, if it's 125 dihydroxycalciferol, that's the version you're looking for.
I love it. I love it. So does vitamin D help the promotion of calcium?
So there's several, so you're talking about in bone?
Yes.
Okay.
Helping the bones absorb the calcium that people either consume from supplements or from foods that they're eating.
Right. So it can be helpful. And there's 2 chemicals that are kind of balancing. There's calcitonin and there's parathyroid hormone, and they counterbalance everything, right? Here's the data that I think is really compelling, and I did include it in one of the books that I did. Americans consume on the average 2,000 milligrams of calcium a day.
Okay.
And this has been promoted by a lot of people. And we still have all this osteoporosis and osteomalacia and, you know, thinned or weakened bone structure. Why is that? It's very simple. They've looked at people around the world and collected the data. The people that have the strongest bones have an average consumption of about 800 to right around 800 milligrams of calcium a day. What's the difference? Why would that work? This is where that conflicting data stuff comes in. 2 things. First off, the more protein you have in your diet, the more you will leach calcium out of your bones. Those people...
Can you just repeat that one more time?
The more protein you have in your diet, the more you will leach calcium out of your bones. Number 1. Number 2, what forms bones in addition to these chemicals we've talked about?
Phosphorus.
Bones form along the line of stress. So you break a bone, you get it put in a cast, and you get told you need to move this, you need to move it. Why? Because when the bone reforms, it moves along the line of stress. Patients who don't move those bones, who just leave them there, produce no stress, and those bones heal poorly. So what do we know? The people around the world who don't have the pathetic bone structure of Americans eat about 800 milligrams of calcium a day. They don't eat as much protein, and they exercise. They form stress along their muscles and their bones are just as healthy at 80 or 90 as they were when they were 30 or 40, because they're getting enough calcium, they're not leaching it out of their bodies, and they're putting it on lines of stress. Did you want to say something? I'm sorry.
I did. So you mentioned exercise.
Right.
Cardio versus weightlifting. Both of them?
Well, so I'm yeah, as a cardiologist, I'm always amazed that there's this, it's like people die to make a dichotomy instead of saying, you know what, maybe there's something good about both, right? If you're only going to do one or the other, you might as well, I think, do neither, because you're not. It's kind of like saying, okay, well, I'm going to put gasoline in the car, but I'm not gonna take care of the oil, or I'm going to take care of the oil, but I'm not going to put gasoline, right? I mean,
Right.
this is silly. There is a benefit to both types. Aerobic, cardiovascular, improves the function of the heart, of the lungs, of the blood flow that gets these nutrients to the extremities and the bones. Weight training, as they call it, putting on lines of stress, can help with the muscle mass and with the bone structure. But if you do one or the other only, you are not going to get your optimum result.
Okay.
And people should embrace the fact that maybe this is not an either or planet.
Okay. Dr. Fleming, we do have a caller. And then I do have like a final thought when we come back after we're done with the callers. And I also want to just ask, so I know that the next vitamin C conference in Clearwater is coming up. I'm hopeful that you're going to be speaking again. I know last year I came with 3 of my favorite doctors from Heber Valley, Dr. Scott Chandler, Dr. Matthew Geddes, and Dr. Ron Dumar. And I have to tell you that the information that you delivered that year, as well as last year, was so powerful. So I'm going to want to wrap up with that, but let's see, Leighton, if you can bring in our caller, that would be great.
All right, let me pull them right up. Hey, Jim, you're on with Laurie, Gagan, and Dr. Richard Fleming. What question do you have for these two today?
Well, my question is, January of this year is carnivore month, and there's a bunch of high-profile people like Joe Rogan that are doing carnivore. And my question was the calcium and the amount of protein that you're eating. Should I add K2 to my diet if I do this? And what are your thoughts on the carnivore diet? Some people think that the good results people experience are because they've eliminated every other thing out of their diet, and some think it has to do with the ruminant animals.
So here's the problem. As we're looking at people that are on carnivore diets, I think by and large people do it to try to lose weight, I think is where they're at. And one of the things that I've tried to explain is that it's not so much the weight that is what you need to be looking at. It's the tissue in your body, the heart tissue, the bone tissue, the kidney tissue, the liver tissue, everything that is responsible for keeping your body healthy. So losing weight, while there's clearly too many Americans and people in the world that are overweight, which is bad for the body, doesn't necessarily mean that the other tissues in your body are getting better. One way that we tend to look at that is we get blood tests, right? We get cholesterol levels, we get homocysteine, we get lipoprotein little a, and a variety of others. But those are all downstream phenomena. In other words, they only go up or they only go down on the extremes. They don't tell you what's actively happening at the tissue where the disease is. For example, about 70% of the people who have a heart attack, damage to their heart, have 30% or less narrowing of the blood flow to the artery just by looking at it. Because the disease in the artery is in the wall of the artery. That's why it's called coronary artery disease. And it's an inability of that artery to relax to increase its blood flow. You can't see that. It doesn't just match weight gain or weight loss. I mean, there are some tremendously overweight people that have very good hearts, but there's an awful lot of very overweight people who have very bad hearts. And the question is, just because you're going to lose weight doesn't mean you're ending up with a healthier body. Well, a good friend of mine was, because I used to be a police officer, a good friend of mine, Gil Hansen, was assistant chief of police in Waterloo, Iowa, where I grew up and where I was a police officer. Gil was a bodybuilder. He was Mr. America, and he won it a couple of times. Gil ate nothing but protein. Gil dropped dead from a massive heart attack, and he looked beautiful in his casket. He was a good friend of mine. I've taken care of priests that were bodybuilders and watched what they ate and ate more and more protein and ended up with heart disease. So I'm not anti-meat. That's not the point. The point is, it's kind of like, is it aerobic or anaerobic exercise? When we go to one extreme or the other, we are undoubtedly missing something for our health. And superficially, if you just look at somebody, you can't tell what's going on at the tissue level. That's why I developed the patent, Fleming method or FMTVADM, depending upon who's talking about it, where we measure what's happening inside the body, which allows us to first figure out if you've got a problem. And secondly, independent upon what you're doing to treat it, we can then measure whether what you're doing is making you better or worse. So I have dealt with the dietary community from one extreme to the other. I mean, I've done decades worth of research in this. I have listened to the response from people. It tends to be very strong. They tend to have an attachment to it. And you're talking to somebody with the last name of Fleming. So Vikings, food is part of what we own on this planet. So Fleming Steakhouse, P.F. Chang's, Bishop's Cafeteria. If you want to eat the food, our family will sell it to you. The question is there a consequence in the end? And your health is more than just losing weight. So hopefully that answered that.
That was helpful. Thank you.
You're welcome. Go eat a cupcake.
All right. Thank you for calling in, Jim. You have a wonderful day, and make sure you check in with us again on next Thursday at 4 p.m. Mountain Standard Time, and you have a wonderful day. All right. I'm going to bring our next caller right on in. Hey, Lior, you are on the line with the Wellness Crusaders and Dr. Richard Fleming. What question do you have for them today?
I just wanted to do a quick recap on vitamin C.
Sorry, can you say that one more time?
I said I'm just going to do a quick recap on vitamin C.
Perfect. I love it.
All right, go on ahead, Lior. What's the recap that you have?
So am I on the air?
You are on the air, and Richard Fleming and Laurie Gagan can hear from you.
Fantastic. Well, thank you so much for having me and Dr. Fleming and Laurie. It is such a pleasure to reconnect with you once again. So I appreciate the opportunity. And what a great podcast. at a very much needed time as we are getting into the winter season with all the various bugs, whether they're viral or bacterial. So I really appreciate your input and highlighting the importance of vitamin C as we're dealing with infectious disease. Having said that, I really appreciate Dr. Fleming's input on the issue of bioavailability and titration. And the reason I'm saying this is because vitamin C is so often misconstrued, misapplied, and misunderstood. And both of you had an opportunity to participate and attend, actually, the annual VCICI symposium, which is solely dedicated on education on vitamin C therapy. And I don't say therapies lightly because vitamin C has the ability to act as a therapeutic if it's properly titrated. And I know today Dr. Fleming had briefly discussed that the importance of properly titrating vitamin C or even vitamin D, but it is such a broad subject and misconception. Both of you have listened and attended some of my lectures, and I often talk about these misconceptions that go back so many decades because it has to do with the politics and maybe cover-up of its very potent abilities as antioxidant, pro-oxidant, antibiotic properties, anti-parasitic, antibacterial, and antiviral. And obviously, when the pandemic started and we were speaking of COVID, it was on the forefront of the news again because it became very popular once again. But vitamin C has been in the news since 1928, I believe. And it has been successfully applied in various infectious diseases and very successfully. In fact, Dr. Klemmer was the one that became very well known for the papers that he published on polio. And altogether, he published 28 scientific papers with various infectious conditions, but the first one of them that demonstrated 100% efficacy had to do with the polio virus. And later, it was Dr. Cathcart who expanded that protocol specifically with sodium ascorbate. In fact, both Dr. Klemmer and Dr. Cathcart utilized sodium ascorbate for the same reason that Dr. Fleming mentioned, and that has to do with the bioavailability and receptors. So the analogy of what type of fuel you put in your body is not only important, but it's fundamental. So you want to make sure that you're utilizing the most bioavailable form of vitamin C and that you're actually implementing therapeutic protocols. Because if someone just buys the readily available ascorbic acid off the shelf, taking maybe 500 milligrams or even 1,000 milligrams a day, which is 1,000 milligrams is 1 gram per day, and you have a raging infection, once again, whether it's a viral or bacterial infection, in this particular instance, it's not going to make a difference because you underdose it. So you're not going to experience the degree of efficacy. And this translates to the bias and misunderstanding and misinterpretation of even the many clinical studies that have been published over the years of PubMed. So I just wanted, can you hear me?
Yes, that was
Yes.
that was actually the great comments, Lior, the bioavailability. And Dr. Fleming, is there anything that you can add to that? Because that was awesome.
Well, I think it may be along the lines of thinking about blood pressure. When you have a patient who comes in and their blood pressure is out of control and you're using a medication to get it under control, you titrate up that dose until you get to the effect that you're looking for. and then you stop. So it's not a new phenomenon to think, wait a minute, not everybody needs the same dose, and we titrate to effect, which is the term that's used medically, titrate to effect. And the effect that you're looking for when you have symptoms to go on is symptoms. If you have tissue data to look at and go on, then you're going based upon tissue data. If you're listening to the lungs with a stethoscope and the pneumonia is gone, but it's still there on the chest x-ray, you've titrated it to the effect of your ears and the stethoscope. So it's always a matter, whether it's SARS-CoV-2 or respiratory syncytial virus or any other thing that you're dealing with, of titrating to effect, dealing with the problem, recognizing you need to stay on top of it. This is the old story for pain management that we used to say, which is, as I was taught, it's better to get on top of a patient's pain with pain medicines, post-surgery, for example, and then slowly get them off the drugs. Because if you try to do low doses up front and they start having pain, it becomes more challenging to get control of the pain. And the goal isn't to chase the pain. The goal is to get on top of the pain, bring it under control, get the person better, get them off the pain medicines, and get them home. So the same thing's true when you're dealing with an infectious process. The goal is to get on top of it, stay ahead of it, knock it down, get them better, get them home. The worst place to be if you're sick is in the hospital, because everybody comes there with their illnesses and share it with everybody. So getting them out of the hospital is critical, and keeping them from getting into the hospital prevents them from getting other illnesses.
I agree. And furthermore, I would like to add to this that because vitamin C is responsible for so many functions and roles in the body. In fact, it is a cofactor for 150 different metabolic functions in the body. And it has therapeutic abilities that have been overlooked for decades. So we have an issue that the wrong form of vitamin C has been broadly used, and then it's been underdosed both in terms of dosing, delivery mechanism or route, frequency, and the duration of treatment. And in fact, in the 2023 symposium, which is the annual conference for VCICI, Dr. Fleming answered that question specifically, because one of the questions that was addressed to me was, well, how long should we continue the treatment for? And again, I know you had a great disclaimer in the beginning, so I'm going to use that term treatment in quotation marks. But if a provider is implementing vitamin C protocol, it needs to be, first of all, implemented in a timely manner. It's very important to understand that. And in fact, it was Dr. Corey and I, who spoke about it a while back ago about the importance of timing when you're addressing especially acute infection. And the same goes with COVID or flu or cold. So you want to get started as quickly as possible. You want to make sure that you are implementing a loading dose, the same, similar in analogy that you will implement with either antibiotics or even anti-inflammatory and steroid type of medication. So we need to, first of all, do the loading dose, because the physiological level and the requirements in most cases is heightened, and most of the patients that are already exhibiting symptoms, they're going to be at a level of deficiency, if not depletion. And I lectured extensively on that at our 2023 symposium on the oxidative stress levels and the ROS, and what dictates the rate of depletion or requirements of ascorbate in the tissue and the blood plasma. So for that reason, again, we need to bring it to the optimal levels first, and then start a treatment protocol that is therapeutic. And everyone's needs are going to vary depending on their oxidative stress level that particular day. Okay, so it has to do with the underlying condition, and it also has to do with their lifestyle. And then you have to continue the duration of the treatment in order to resolve all symptoms. So in integrative medicine, or complementary, alternative, holistic, natural medicine, whatever, however you want to address it. But in the integrative medicine is not looking only into resolution of symptoms, but we're actually looking in addressing the root cause of what prompted this. And so in the beginning of your show, Laurie, you spoke about, well, why are we more susceptible to these viruses and what can we do to prevent that? So if you maintain optimal physiological levels on a daily basis of ascorbate levels in the body with the right form of medical grade vitamin C, you ultimately created an invisible bubble around you. So when you do get on that plane and you do touch all the doorknobs without disinfecting them first with some sanitary wipes, you're still protected because you have an internal biofilm or bioshield, so to speak, to protect you. Why? Because your immune system is robust. And that is the core responsibility, so to speak, or one of the functions and roles of vitamin C as an antioxidant.
I love that feedback. How can our listeners find more before we're getting ready to end the call, but how can our listeners find more information about your talks on vitamin C?
Well, we have a lecture series that is coming up on February 28th at 6 p.m. Eastern Time, which is going to be a webinar for healthcare practitioners. So if you're a healthcare provider, this is not a webinar you want to miss. So please go to vcici.org, and it stands for Vitamin C International Consortium Institute.org. And we offer this webinar complimentary to all members, which if you're not a member, there's a fee. You can still participate in it. But if you go to vcici.org or send an email to support@vcici.org, you can register for that 5-hour lecture series provided in two parts, one on February 28th, and the second one, I believe it is March 6th. And you can register for that lecture series. If you're a patient, you can become a member, and we will be offering some informative webinars also for the public. But this particular webinar is focused and geared towards healthcare providers. In addition to that, we're hoping to bring another annual symposium in October of this year, but if not, we're going to be providing a series of webinars. So there's quite a bit of information available on the vcici.org website, and if you have any particular questions, you can reach out to us and ask a question, and we'll do our best to respond. If anyone is interested in the medical grade sodium ascorbate vitamin C, they can find that information on pur-c.com. Again, that is only available to healthcare providers. So if you do have an integrative healthcare provider who's interested in that, please direct them to that website.
Great. Thank you so much for sharing that information, and I appreciate your call, and have a good evening. I think, Dr. Fleming, we have another, one more caller, and then we're going to wrap up with how do people find you and all of your work that you've been researching and working on. So, Leighton, do you want to bring the next caller in, please?
Yep. All right. I'm bringing the next caller up right now. All right. Liam, you're on with the Wellness Crusaders. What question do you have for Laurie Gagan and Dr. Richard Fleming?
Hello, Dr. Fleming. My question to you is, what supplementation do you use on a daily basis for your own health? And the other question is, how much protein do you think is adequate for adult male?
Right. So
Great
I don't
question.
actually, right. I don't actually take any supplements of any sort. you know, the regimen that I do as far as food is, I'm a pescatarian for people who really care. And I have reasons for doing that, and it has to do with NER5AC receptors and antigen responses. The research that was done looking at how much the average individual needs in protein really carries back to research that the United States carried out on conscientious objectors during World War II and a couple of decades before that. And what happened was they took individuals that didn't want to fight in the war and they put them on camps in Wisconsin and Minnesota, and they exercised them, did activities, changed the amount of protein, carbohydrate, fat they had in their diet, the number of calories they had in their diet. And they came up with some very interesting results that have stood the test of time. One is how much protein that you need in a day, and it turns out to be 0.4 grams per kilogram body weight. So if you take your pounds, divide by 2.2 to get the kilograms, multiplied by 0.4, you find out what you need. And we've used this in patients who have been hospitalized for many decades. And it pans out. It turns out that if you go above that, you end up with the kidneys having to deal with the excess amino acids from the protein, sometimes the liver. That can lead to kidney problems. People that are on dialysis have to have their protein cut back even more because the kidneys dump that extra amino acid in the form of what's called urea and acid, and that's nitrogen waste, which comes from proteins. It also turns out that you can get too little protein in your diet. And they discovered that if you actually cut it down to 0.2 grams, milligrams per kilo per day, people would lose muscle mass, and they would lose it at such a rate that they could not recover it. So they took that data to make those calculations and figure out what it is. By and large, that cuts true for most people. There's always the exception of the person who claims that they want to be a bodybuilder. My friend Gil Hansen was no exception. The priest I was talking about, who was a Mr. America weightlifter, he was no exception. Everybody thinks that they are the exception to the rule. And sometimes there are exceptions, but by and large, you can look at the vast majority of individuals and figure that out. It turns out to be 0.4 milligrams per kilogram body weight.
Can I ask a question, Dr.
Sure.
Fleming, and just in regards to that as we wrap this up? So recommendation, do you recommend red meat, chicken, and fish? I mean, I know why you're a pescatarian, but if someone can you eat too much red meat versus everything in moderation, which we go kind of back to Hippocrates, but
you can eat too much of anything. You can drink too much water, right? And kill people. It turns out that, you know, the differences between pescatarian has to do with the NER5AC. So you can also get fowl and that type of thing. But the land animals, by and large, and again, Fleming Steakhouse, if you want it, my cousins will sell it to you, folks. And, you know, they are antigenically different than humans. And that produces the same type of interaction, the inflammatory thrombotic response over the course of time that we've seen. And it's just looking at the data. It's not anything else. Again, like I said, my family runs restaurants, runs food chains. They will sell people what they want. It's to me, it's about science and just being very clean on it. And just dealing with the data that's presented to us.
Can I ask one more question? I know we're
Sure.
a little bit over time. What are your thoughts on what you were just saying versus eating red meat that is grass-fed, grass-finished? Is there any difference? And I've got a friend of mine who's very curious about that.
Yeah.
Does it change anything?
The only difference is how much saturated fat or fat there is in the animal. The grain-fed ones tend to be leaner, which produces less of the saturated fat issue, but they're anagenically the same animal. You take an animal this is one of the things I find fascinating about some of the conversation going on in society. You take an animal, that animal is that animal. I mean, if you know, you take a bison, and if it decides it wants to call itself a cow, I guess it can call itself a cow, but it's still a bison. It's still anagenically a bison. It's still going to have the same effect when you consume it as a bison. Whether it eats grass or whether it eats wheat is going to be a matter of how much weight it is and how fat it is. But anagenically, what it is still a bison, right? So no, that does not change that.
Okay. Well, we appreciate you calling in. And Dr. Fleming, we're going to go to the wrap-up question. And I so appreciate you, as always, giving us the information that is so hard to find. So how can we find you and all of your decades of research and work for people who are looking to find the truth on COVID, RSV, the cold, and the flu?
So there's several places that I have material. I mean, one is on FlemingMethod.com, just all one word, one M in Fleming, no stuttering. And obviously not everything's on there, but it's an effort to try to get information in a variety of topics, including an awful lot about SARS-CoV-2/COVID, because that's been a very hot topic and it's involved a lot of people, and trying to explain how this inflammatory thrombotic response is related to all these diseases like COVID, cancer, diabetes, heart disease, the work that I've done on being able to measure it and to establish bringing the patented method out so people can use it. I mean, during the pandemic, I used it, I gave it for free to the centers that I trained how to do it so we could get answers about what did and didn't work. But it's something that's focused on finding a problem and then allowing us to determine if whatever treatment you do want to do actually works for you, which I think is critical, tailoring it to the person. 10letters.org is one way to get actively involved in dealing with this biological weapon that they developed, SARS-CoV-2, and the genetic sequences that are in the vaccines that emulate that biological weapon.
And how are you spelling 10letters.org?
Correctly. So the number 10, followed by the word letters, letters.org. So 10letters.org.
Thank you.
Wouldn't you love to be one of my students in class, right? So that's an option. I'm on Rumble at different places. You can find me on Twitter. My real goal is to constantly just kind of keep pushing through on the work that I'm doing, you know, because many decades of science and medicine, and I just realized it was 10 years ago this month that I graduated from law college and became an attorney, for crying out loud. All these things to keep pushing them forward and to get the information out. I'm actively involved on doing that. There's books that I've written that you can find out there. And another one that I'm finishing up right now that is going to be much more all-encompassing to try and help people come to terms with where we're at and why we're here and what you can do about it. So those types of things are there. But and I guess if we're here next week, to turn in next week and listen to your questions.
All right. Well, Dr. Fleming, I truly appreciate you, and may God bless you and the journey that you are on. And have a good evening, sir.
Thank you. My pleasure to be here. Thank you.